Okay, in this audio lecture we're going to be covering COPD, otherwise known as chronic obstructive pulmonary disease. Okay, so this is a really big disease and is thought that is going underestimated in the world or in the United States today because smoking is a very large cause of the COPD, and we see that COPD oftentimes gets masked by really the manifestations that smoking can induce. And so we see that it's the third leading cause of death in Americans, and then we also see that it affects probably more than 15 million people. Really, this chronic obstructive pulmonary disease is really a combination of disorders, and so primarily it has chronic bronchitis and then emphysema that contribute towards it. And so bronchitis is the narrowing of the bronchioles through inflammation, and then emphysema is destruction of alveolar walls, causing abnormal function. So we see that this is really a debilitating set of chronic disorders that doesn't show up overnight, but shows up over time instead. So we see COPD as the result of really a couple disorders, emphysema and chronic bronchitis. That is specifically different from acute bronchitis, and that is not caused by a bacterial infection. And emphysema, where we get it affecting the alveolar wall. So we're getting changes in the ventilation of the lungs, and so the movement of air through the respiratory passages, and then also the exchange of these gases as well. So this can result in severe hypoxia. So if we reduce the amount of air that we can get to our alveoli, can result in hypoxia. And then if we decrease the exchange between gases between our alveoli and our blood, then we get hypoxia and hypercapnia generating. So this decreased movement of air and the decreased exchange, decreased perfusion, can result in these manifestations of hypoxia, which is low environmental oxygen, and hypercapnia, which is elevated carbon dioxide. Eventually, this can result in respiratory failure, and we'll detail that in another audio lecture. So what happens is this oxygen begins to drive the breathing. So normally it's carbon dioxide and pH more specifically that drives ventilatory demand. And instead here we see that since CO2 levels are increasing fairly substantially, that we begin to be kind of immune or sensitized to the carbon dioxide, or desensitized rather to the carbon dioxide, and we're switching to oxygen driving our ventilation. Okay. This can result in cor pulmonale, and so we see cor pulmonale, there's changes to the right side of the heart, and specifically this could lead to a right side of the heart failure. Okay. So we see that COPD is caused by a number of factors, including cigarettes, pollution, and then chemical irritants. By far, the highest cause of this is cigarette smoking. Okay, so cigarette smoking produces the COPD because it can result in chronic bronchitis and emphysema, both of which are two conditions involved in the COPD. So we see that the COPD initially is asymptomatic because of the effects of smoking. So we just attribute a lot of these effects and the hypoxia that is present in the increased carbon dioxide to smoking rather than what we should be doing, which is lung damage. So we have two main conditions that make up COPD, and I've mentioned them a few times. We have chronic bronchitis, which is chronic inflammation of our bronchioles, not due to a bacterial infection. And then we have emphysema, which is destruction of the alveoli. Remember that the alveoli is where we exchange gases. So if we inhibit really the function of the gases, then we can decrease our gas exchanges, so we decrease our oxygen levels and increase our carbon dioxide levels, resulting in hypoxia and or hypercapnia. So the first condition we have here is chronic bronchitis, and so we see in chronic bronchitis, this is also known as blue bloaters. So the individuals oftentimes will kind of give a blue appearance, and so what we have in this condition is chronic inflammation of the bronchi. And so we actually are not exchanging proper gases, so meaning we cannot get the alveoli, the gases, resulting from mucus production and then bronchoconstriction. So we have a chronic inflammation event resulting in narrowing of the airway passages. Okay, so remember that we have this smooth muscle on the outside, and we have endothelial cells, epithelial cells along this inside, and then it becomes inflamed, it becomes thick, and we start hyperproducing mucus, and this airway is becoming smaller and smaller and smaller. So you might expect to hear some wheezing from somebody who suffers from chronic bronchitis. Bronchoconstriction would be just activation of our smooth muscle, okay, narrowing this airway even further. And so here's a normal airway over here. Here's one that is undergoing bronchitis right now, and this is an inflammation event that is starting all this due to chronic irritation. Okay. So it's not caused by an infection like acute bronchitis was, but it is caused by the irritants found in cigarette smoke most oftentimes. Now, like we said, we could have other causes of this as well, and so other causes might include pollution or allergens. So, some complications of chronic bronchitis can include frequent respiratory infections. Anytime that we increase mucus production, we're really inhibiting our ability to get that mucus out of our pulmonary system, so it's building up in there. This can result in a bacterial breeding hotbed. Okay. And so we have impaired immune defenses because now we can't actually mount an immune response because we have too thick of a mucus secretion. So not only do we see more production of mucus, but we see more production of mucus secreting glands. So remember that these are called goblet cells, back from your days in anatomy and physiology. So we could get respiratory failure due to the increased resistance to airflow. So anytime we are narrowing the passage, we are making it more difficult for the air to move down our respiratory passages, eventually getting to the alveoli. That is at the end of our respiratory bronchioles and then our bronchioles specifically. Okay. So some manifestations of chronic bronchitis can include cyanosis. So a cough, a productive cough, and so this is due to the increased production of mucus. Okay, hypoxia, hypercapnia, respiratory acidosis is going to result from that hypercapnia. So if you think about the function of our lungs, it is to expel carbon dioxide, to sequester oxygen from the environment. Okay, and if we can't expel enough carbon dioxide, well, part of carbon dioxide is converted into hydrogen ions. And so as this carbon dioxide starts to build up in our body, we can become acidotic, right? So our pH begins to drop. Since we have hypoxia, okay, we get an increase in hemoglobin content, right? So your arterial blood gases might demonstrate a lower oxygen, and then your CBC count might indicate an elevation in red blood cells or polycythemia. So we see hypoxemia, cyanosis, that's why they call it blue, and they call it bloaters because we start to see that right-sided heart failure because now it just is not, things are not working efficiently. Okay, and we can get an edema-like function. Okay? So oftentimes when you see people walking around with oxygen, supplemental oxygen, and the nose tubes, they are trying to supplement the environmental oxygen to increase the exchange, right? So now we are increasing the concentration to increase the difference between environmental and then our oxygenated, our blood oxygenated. And the more we create that concentration difference, the more oxygen will diffuse into our blood. We see polycythemia, so the increase in red blood cells, clubbing of digits, and I had never heard of this. I don't know why this happens. I tried to find a reason, couldn't find a reason in the half an hour that I spent on this. Okay. And so we see the mechanism, these clubbing of fingers starts to happen. This is an indicator. We have dyspnea, which is labored breathing. We have some additional manifestations like wheezing or rales or rhonchi. And so we would be listening for these abnormal sounds. Edema, okay, is going to happen over here. So this is where the term bloater comes from. Is blue bloater because cyanosis is present, and then we also see edema is present. And this dragon here has not figured out not to stop smoke. Has not figured out to stop smoking yet. So because of the edema, we might undergo some weight gain as a consequence of that. As a result of this increased polycythemia, the heart's going to grow. It's going to have to generate more pressure to move the blood because now the viscosity of the blood is becoming thicker, and it's causing more. It's requiring more pressure to move it. We might experience some standard symptoms like malaise, fever, or chest pain. Right. So the chest pain would be due to various reasons, and if it develops into angina, which is pretty much a sign of a heart attack, it can be pretty serious. Okay, so how are we going to diagnose chronic bronchitis? Okay. History and physical examination, so see how long the person's been smoking for, see what kind of allergens they're exposed to, environmental pollution, pollutants. And so you need to meet some certain criteria to be diagnosed with chronic bronchitis. First of all, you need a persistent, productive cough, right? So it has to happen for at least 3 months out of the year, and then for at least 2 consecutive years. So this isn't something, this is occurring over a long period of time for them to be able to officially diagnose you with this chronic bronchitis. Now, if you have this, the physicians probably have a good idea that you have this condition. They're going to do a chest x-ray to look at really your airways, make sure they're clear. If they're not clear, that's an indicator. Pulmonary function test, so here we're going to be looking at spirometry to look at pulmonary function. So if your expiratory volume is decreased, that is probably a very large indicator. And if your inspiratory flow velocity is decreased, that is probably suggesting that it is undergoing increased resistance on the pathway to the alveoli. Next, we're going to take an ABG. So an ABG is an arterial blood gas, and we're going to expect the arterial blood gas to be hypoxemic, right? So have a decreased carrying capacity of oxygen. Now, along with that, we're going to do a complete blood count. And so we would expect in our complete blood count to suggest that erythrocytes are increasing in function. Now, we wouldn't expect any change in leukocytes unless we're suffering from another infection, because this is not due to a bacterial infection, but due to inflammation of the bronchioles. So how are we going to treat bronchitis? Maintain airway patency. Right? So we might deliver more oxygen, but you need to be careful with this because oxygen begins to drive ventilation this is from the original what is it science, right? So as you become more dependent on oxygen, if you supplement with an environmental oxygen, it's going to knock away that drive, and so you might actually start to hypoventilate or stop breathing altogether if oxygen levels get too high, because this is a sign that says, so usually we use carbon dioxide because as carbon dioxide builds up, that drives our response to breathe, right, to prevent this increase in carbon dioxide. Now we switch to oxygen, which usually doesn't go above atmospheric levels, but here we are switching it to a supplemented oxygen source. And so this increased oxygen might actually shut down the drive to breathe, and now you could go into respiratory distress. We could use pharmacology, and this is going to include bronchodilators, corticosteroids, which are going to try to open up the airways. They're going to work to combat that inflammatory response. We see that if antibiotics are present living in the mucus, now this chronic bronchitis is not due to a bacterial origin, but it can lead you to increased incidence of bacterial infections. Okay. One thing that can help with this is postural drainage, right? So changing your posture to allow drainage of the mucus that is accumulating in your respiratory system to escape, right? And it might require cupping or clapping, right? So this is the chest physiotherapy to encourage that mucus to release and then to be produced, the removal from the body. Yeah. Just like with any kind of mucus disorder, we're going to try to deliver in kind of inflammatory disorder that increases mucus production. We're going to try to reduce or liquefy that mucus to make it easier to get out, because mucus, when it is dehydrated, is very, very sticky. It's almost like glue. And so if you don't increase hydration, you can't liquefy that substance and get it out of your body. Okay. Now into the next cause of COPD, or the next factor of COPD, and this is emphysema. And so this is called pink puffers, right? So it's another name for that, whereas chronic bronchitis was blue bloaters because of the cyanosis that we see, and then from the edema that we also see. So this is an obstructive disorder, and that leads to the destruction of alveolar walls. And so this destruction of alveolar walls, so if you look at this alveoli right here, you have these alveolar walls that increase respiratory exchange surfaces. Now in this emphysema here, these respiratory exchange surfaces are destroyed, and so effectively we have reduced the surface area of our lung to exchange gases. And so another result of this is that we can actually get hyperinflation of the alveoli, because now we've damaged the elastin tissue that is covering our alveoli. So this is normally elastin tissue that, remember, has the ability to stretch and it has the ability to recoil, an important function of alveoli. So we see that the damage to the elastin actually damages the alveoli and their ability to stretch and their ability to recoil. So they stretch, but they don't recoil. And so this is due to direct damage on the elastin fibers, and also damage to the alveoli and the production of an enzyme that repairs elastin and also repairs the alveolar surfaces, because the lungs are actually highly regenerative, but we need to make sure the damage isn't so extensive, and really we're causing DNA damage here by changing the ability to produce this enzyme. Okay. Common causes are smoking and genetics. So same things that we saw for chronic bronchitis and COPD, smoking, right? So genetics can also increase the likelihood of this emphysema, but really this is a minor portion. Most of the emphysema cases are really from the smoking, a completely voluntary decision, a lifestyle decision that is going to impact the rest of your life. So we see alveolar destruction. So here's an X-ray of a couple lungs, and then so here's a normal patient. We have normal lungs expanding all the way out to the thoracic cavity. So the pleural cavity would be between these two tissues, and over here we have a diseased lung, a COPD lung, and specifically emphysema. So what we've done is we have an inability to actually compress our lung because it stays kind of inflated when we actually exhale. Hence, we'll see what manifestation actually can result in that, but it can result in chest, barrel chest, so this thick chest. And so you get destruction of the alveoli, both the internal alveolar walls and the elastic fibers. So remember that we have a couple different types of alveolar cells in our lungs. We have type 1 alveolar cells, and that is where we actually get exchanges of gas. So, and then we have type 2 alveolar cells, which are right here, and they're going to produce surfactant. Surfactant is the chemical that we secrete onto our alveolar surfaces to enable prevent the lung from expanding too much, and then also preventing it from collapsing. So it reduces surface tension in our alveoli, because water itself has a really high surface tension, right? So when it's around each other, it really wants to be together, and so it could lead to collapse of our alveoli. The surfactant reduces that surface tension, reducing the drive to really collapse. Okay. So the alveoli cannot recoil. Okay, so inspiration is not affected by emphysema, but rather the recoiling of our lungs is a passive process. So we don't really, unless we're using forced expiration, we don't try to breathe out forcefully most of the time. We just exhale naturally, right? So through a passive process, not when you're talking, but just when you're just undergoing normal breathing. This process is normally a passive process due to the alveoli due to the elastin on the alveoli that allows it to recoil. And without these alveoli, or without these elastin molecules acting on the alveoli, so it's just like a rubber band, right? So you stretch it, and then you reduce the pressure on it. Now it snaps back to shape, and that's what we see when we look at the alveoli. And this can result in this idea, I already mentioned it, as a barrel chest. So a inflated chest after you have stopped breathing, so the air becomes trapped in there. Some manifestations of emphysema can include dyspnea upon exertion, so labored breathing after you're trying to do things, diminished breath sounds, so when they listen to your breathing via stethoscope, it might not sound like the lungs are moving as much, and that's because of the damage that you've done to the alveolar walls and the elastic fibers. This could result in wheezing or chest tightness. So after you take a big breath, okay, does the chest feel tight after? And so this is an indication of emphysema, meaning that you don't feel like you fully exhausted that air that was in your chest. Okay. Tachypnea, because now your breathing is starting to be reduced, and so you need to take more superficial breaths, and so we see that you increase your carbon dioxide because you're actually not breathing out that much. Okay. We can see hypoxia begin to occur, hypercapnia begin to occur, all as a result. So the COPD in general, hypercapnia and hypoxia are common problems, not only from bronchitis but also from emphysema. So you could see an increased diameter of the chest, and so this refers to this. So this little cartoon here is really indicative of is a barrel chest, right? So this person here who hasn't quit smoking yet, it's another dragon, similar to the first one, but we saw edema. In this one, we see somebody who's lost a lot of weight and they have a barrel chest, so they have a real thick, round chest in response to the emphysema. Okay. This person is likely going to be intolerant to activity. They might be fatigued. They're suffering from anorexia. So anorexia, given the weight loss that they're having. A malaise, a general ill feeling. Some more manifestations on this picture here. So we can see some anxiety start to begin, short, jerky sentences because they have a difficult time actually getting the air out of the respiratory system. So we can see that several things are associated with that: prolonged expiratory time, jerky sentences. They require additional muscles to breathe, right? So now they're actually going to be activating their abdominis rectus or their scalenes or their intercostal muscles to breathe, right? Ultimately, this can lead to right-sided heart failure. So how is chronic emphysema going to be diagnosed? This is the same as chronic bronchitis. So we're going to look at the physical and history of the individual. We're looking for a persistent and productive cough for at least 3 months out of the year for 2 consecutive years. We're going to be using a chest x-ray, and this would really show up as 2 different things. So the chest x-ray from chronic bronchitis is going to show a narrowing of the airways, whereas in emphysema, we're going to be looking for we might take an x-ray of an individual when they take a breath and then one when they exhale, and so this comparison would still show a partially inflated lung, partially inflated, which they always are partially inflated, but it's going to be more. They might use a forced expiratory test to see if it can go down even more. Pulmonary function tests, so they're going to be looking at spirometry. Arterial blood gases are going to indicate a reduction in partial pressure of oxygen. Right? And then the complete blood count is going to indicate really a polycythemia, so this increase in red blood cells to try to carry around more oxygen. How are we going to treat it? Same as chronic bronchitis. We're going to use oxygen therapy, but we need to provide care, practice care with that oxygen therapy, because really the drive to breathe is mediated by oxygen instead of carbon dioxide. We're going to use various pharmacological techniques, including antibiotics, corticosteroids, and bronchodilators. Okay. If the infection is present, we're going to use antibiotics. We wouldn't use antibiotics unnecessarily. We are going to try to use procedural drainage, and then chest physiotherapy, which again is the cupping or the clapping on the back, and so this would loosen up any phlegm, increase hydration, increases liquefaction of the mucus. Now, there's one additional technique that we're going to use here for treatment, and it's going to be pursed breathing. And so this pursed breathing is going to be through a closed mouth, really. And so we're going to try to exhale through this closed mouth, and to breathe through that closed mouth, you have to use your accessory muscles, like your rectus abdominis and your intercostal muscles, um, to help move that air. So that is the end of the audio lecture over COPD, and specifically over chronic bronchitis and emphysema, right? So you should be tying together how chronic bronchitis and emphysema both lead to this chronic obstructive pulmonary disease, and that they really prevent air from moving into the respiratory passage. So from emphysema, it is preventing air moving in because we are trapping air essentially inside of our alveoli. And then from chronic bronchitis, it's reducing the airway diameter, and we're making it more difficult to move that air into our respiratory passages. Until next time.